for the students. So with this in mind, I'd like to turn over to Professor Cheng. The floor is yes. And I don't know which you like to have share screen, Professor Cheng.
Yes. Before you share screen.
Yes. Yes.
So yeah. So thank you for this opportunity. Over the last few years, I've had much more contacts with colleagues in Indonesia, and it's easy to travel there before the Corona season for all the meetings and the workshop. What I have done was to, I've sent to Adrianta the 3 sets of notes, and he will share with you later. But we probably have time to just look at one of them, which are basically a list of questions that I've compiled. We're all teachers here. So instead of doing it as a review lecture, which you won't have time to cover everything, I thought that perhaps by using questions, we can look at some of the essential concepts that are asked by using these questions. So the way to approach this list of questions, I've called them, this is a pun on the word Wi-Fi. So this is Wi-Fi, as in W-H-Y-P-H-Y, Wi-Fi lungs, okay? So this is a list of questions, about 30 of them here. We will do as many as we can within the next 60 or 75 minutes. And then we can always follow up in the next couple of weeks or so, yeah. So I want to encourage the younger teachers amongst us, especially to, if you can, to actually archive and compile your questions. So I've been teaching more than 30 years. So one of my regular activity is basically to try to formulate questions for the students. And it was interesting for me to hear one speaker, in fact, it was 2 years ago, saying that you could literally teach a lecture through a series of questions, because questions actually can highlight essential concepts. And so he says that you could actually do that if you formulate your questions very well. And so for the younger teachers, and I was once a younger teacher, so as you compile your questions and over the years, as you look at your questions, you will find, hopefully, that your questions would have evolved as a physiology teacher to be more probing and challenging the students to think through physiology in a more integrative way. So I also realized that when I first started teaching, that most of the questions were quite direct and descriptive. But over the years, becoming more familiar with whole body physiology, you begin to learn yourself how to ask more integrative thinking questions for students to think about physiology. And this is basically how the international quiz has evolved. As a result of years of asking questions, we able to develop important essential questions that were used during the IMSPQ. Yeah. So we are already in the 18th year this year. Last year, Jakarta hosted the quiz. It was a very memorable event. This year, as Adrianta said, we have the 18th IMSPQ has also been COVIDated. So we have in its place replaced it with the online physiology art competition. Yeah. So so we will run through the questions, and I will just highlight to all of you teachers without explaining too much, since you're familiar with the organ system, why the question is asked. I think that's more important. And I will highlight certain things that we should highlight to the student, and how each of these questions can be used as a platform for you to ask or explain further aspect of respiratory physiology. Yeah, so with that, Adrianta, if you can share the first document, Word document, Wi-Fi lungs. Yeah.
Okay, I will try to share. Can you see everybody?
Not yet. Okay, great. Yeah, Wi-Fi lungs. Okay, great. Thank you.
Okay, okay.
Yeah. So I am still getting used to Zoom. So I thought that so that I don't get distracted, I asked the host to share it so that in case on this side in Malaysia, something goes wrong with the hosting. Yeah. Okay. So we have about 30 questions. So I'm just going to go through it and then feel free to unmute and ask or maybe give some input into your own experience with teaching so that we can all learn from one another. I have called this sometimes in my talk homeostatic teaching because we need feedback from one another to improve our own teaching. Yeah. So so we'll just run through this and then please, yeah, as I said, feel free to. This is not a talk, a mini talk. It's an introduction. First question, why is alveolar ventilation always less than pulmonary ventilation? So obviously, in every organ system, the students encounter new words. So we need to define them, define those words for them. So the definitions has become increasingly more important in my own experience. And so and that's the reason why we've started to write a series of books on defining physiology. So the first volume is out on cardiovascular, respiratory, and renal. So obviously students need to understand the meaning of alveolar ventilation and the difference between that and pulmonary. So obviously the concept we are trying to remind the student here is that there is the anatomical dead space. Pulmonary ventilation includes ventilating the anatomical dead space where no exchange of gases occurs, obviously. Whereas alveolar ventilation, we are only interested in the respiratory zone. So that means minus ventilation of the dead space. So this question is asked to remind the student of the concept of alveolar ventilation refreshing. The tidal volume does not all go to the respiratory alveolar zone. You have to minus the anatomical dead space and so on. So this is just the basic equation of alveolar ventilation: tidal volume minus anatomical dead space, and then you multiply by the frequency of breathing. That gives the alveolar ventilation. So so the alveolar ventilation is always less. Yeah. Yeah. So you notice the word always here. Students have sometimes been. If this was a true false question, if you still use that in your medical school, students are always told that if you see a sentence that has the word always, is most likely wrong. but in this situation, it's always correct. Okay, alveolar ventilation is always less. So I have compiled a list of always physiology sentence, and this is actually quite useful because it makes certain definite sentences and it challenges students to be more confident of their physiology. Yeah. So this is one instance where you say the alveolar ventilation is always less than pulmonary ventilation. The answer is true. It's always true. Okay, because of the anatomical dead space. Yeah. So this is question 1. Feel free to chip in, as I said. Okay, if you have any. Yes, please.
When I give this, I give to calculate a patient or three boys, the same age, the same height, and they have tidal volume 12 times 500 milliliters. The other has 6 times 1000 milliliters, and the other has 12 times 250 milliliters. So the pulmonary ventilation or minute ventilation is the same.
Right.
And then I ask which one has an advantage of the alveolar ventilation.
Yeah. Yeah.
As some friends here also done this as a calculation during the lecture. Thanks.
Yeah. So yeah, you can use some values which will be very useful to help students to see quantitative aspect of physiology. Yeah. So there are two basic pattern of breathing. It can be deep and low frequency, or in some patients it can be fast. The frequency is high, but the tidal volume is shallow. So it's rapid, shallow breathing. And so because of the importance of refreshing the respiratory zone, if your tidal volume is shallow and becomes less than your anatomical dead space, then you will not get any alveolar ventilation, although your total pulmonary ventilation, as Adrianta said, may actually be the same. Yeah.
Any other comments? Is it clear? You also can put your question in the chat box, I think. So then we can later also return to question number 1. If you just say, I like that Professor Cheng repeat question 1. So just simple like that. You don't have to make long sentences. Prof Cheng, repeat number 1, then it's okay.
Yeah.
Okay, go ahead, Prof Cheng.
Let's move on. Yeah. Okay. So the lungs are elastic structure, and this word, obviously, elastic recoil, is not peculiar to respiratory system. We also talk about elastic recoil of the blood vessel. So the cardiorespiratory system has many common words, and it's important to define them in both the system. So, and also the word compliance in this question is also applied to the blood vessel. We also talk about arterial compliance. And so there are many common key words in the cardiorespiratory system, which if the students understand it properly, it helps them to appreciate the physiology better. So this question, why is the elastic recoil of the lungs inversely related to lung compliance? So for all of us teachers, this is not so difficult to appreciate. The lung compliance is inversely related to the elastance or the elasticity. So the only thing I want to mention here is that for some of my students, sometimes the common use of the word elastic gives a non-physiological meaning, because when you go shopping, I tell my students, if you are buying something elastic, it seems to give the impression that that structure can be easily stretched. Like you buy a more elastic trousers so that you can accommodate your greater volume. But in physiology, we remind the students that if a structure is elastic, it actually has elastic recoil. And in physiology, it actually means that it is harder to stretch that structure. There is elasticity has elastic recoil, which opposes the distending force to stretch it. So that is why the compliance in physiology is always inversely related to the elasticity. Okay, yeah. So this is just a physiological definition that the elastic recoil of the lungs inversely related to lung compliance. Yeah.
Yeah. When we give the lecture for lung compliance, we usually draw the curves, yeah?
Right.
Volume and pressure. And compliance is delta volume per delta pressure. So the slope of these curves can be different. If it's shifted to the right, then you have less delta volume, and it's like fibrosis. Fibrosis, the curve shift to the right or lower, yeah? Now, usually we get difficulty if the shift is to the left, that is increased, delta volume per pressure is increased. And that's in emphysema.
Mm-hmm.
Then the students say, that is good, it's increased. But for emphysema, it's not good. So we have to explain. Please, Dr. Cheng, explain this.
Yeah. Okay. This was I was going to say something about that in about emphysema. Let's skip to question 4 since Adrianta has mentioned the emphysema. Okay.
Okay.
And we can return to question 3. Now, this one here, the functional residual capacity, FRC, is obviously the volume of the lungs at the end of a normal expiration, normal breath. So this volume is actually dependent on the two structures. They are opposed, sorry, not opposed, opposed to one another. So, so the lung recoil is always inwards. From the time of birth, your lung has expanded. So it's like a balloon. If you give it a chance, the lung will always collapse, recoil inwards. But the lung do not collapse because it is part of this chest wall, chest structure, where it is balanced by an opposing recoil force. So the FRC of the lung is, the volume is dependent on the two opposite recoil forces, the inward lung recoil, which is balanced by the outward chest recoil. So now coming back to emphysema, so all of you are clinicians, and that is, there is a tendency to have increased FRC in emphysema patient. They tend to have this enlarged volume. So if you understand this balance of forces between the inward recoil and the outward recoil of the chest wall, you find that in emphysema, it is obviously a destructive lung disease. And one of the structures that are destroyed in emphysema is obviously the elastic tissue. Okay, so in other words, you lose the elastic recoil in emphysema patient where there is enzymes like elastase that breaks down the elastic tissue. And so if you go back to question 4, if the FRC is a balance between inward elastic recoil of the lung and the outward chest wall recoil, if you lose the inward elastic lung recoil as in emphysema, then the equilibrium will shift to more outward, isn't it? Because the inward recoil is less, inward elastic lung recoil is less, and the outward chest recoil is still normal. So that explains, that contributes to why the FRC in the lungs of an emphysematous patient is abnormally bigger. Yeah. Okay.
Dr. Cheng, you skipped number 3.
Yes, I know. Yes, because I wanted to develop and answer your question about the abnormal compliance. So the emphysema that has lost its elasticity. So you go back to the question 2. We just said that the elasticity is inversely related to lung compliance. So in the emphysema patient who has lost elastic tissue and elastic recoil, the compliance, as Adrianta said, you look at the curve, it's shifted to the left. It's an abnormal increase in lung compliance, which also explains why the FRC is now bigger. Yeah. Okay, shall we go back to question 3?
Yes.
Yeah, so I also realized that, for example, in my faculty, we have lost the format of writing physiology for exam, partly because of the requirement to standardize, and also because of the large number of students. And so for the last 8 years now, since we inherited or adopted an integrated curriculum from some overseas university, at least the first year students, all their exams are basically responding to single best answer. They don't write a single word. So I have, for my medical students, I have not marked any physiology answers for the last 8 years. And I think, of course, we have to move with the times, but I think we are losing, as teachers, an opportunity to see how students express the answer. And writing physiology is, I think, quite important because it does tell us whether the students have understood the physiology. So that's why in a question like this, why is normal breathing called negative pressure breathing? When I ask this in my tutorial, where I get a chance to hear the student, you'll be surprised that in a group of 20 students, you might get actually more than half a dozen different answers. So what seems to be quite a straightforward question, when they are asked to write and express how they are thinking, you will find that actually there are many areas that needs a bit more accuracy in the answers. Okay, so why is normal breathing called negative pressure breathing? Sometimes this question is rephrased by asking, what does the negative in negative pressure breathing means? It means what is it referring to? So for all of us, I think we know that this is obviously in relation to the reference atmospheric pressure, which is given 0. It is not 0, obviously. It's 760. So for air to move, you need a difference in pressure. So with reference to atmospheric pressure, which is a constant reference 0, the only way in which air will move into the lung is if the alveolar air pressure becomes less than 0. So this is the meaning of negative pressure breathing. That means the alveolar air pressure has to be less than atmospheric pressure before the difference in pressure can move your tidal volume in. So, so the students can explain it in various ways, but they need to get the main concept that normal breathing involves finally making the alveolar air pressure negative with reference to the atmospheric 0, then air moves in. Yeah. And so in normal expiration, same thing happens. The alveolar pressure becomes positive, more than 0 with reference to atmosphere. And so expired tidal volume goes up. Yeah. Okay. So, of course, when you use this question as a platform, you can actually cover quite a lot of other pressures, which are very important in respiratory physiology. respiratory physiology, there are a lot of pressures. So I tell students that learning respiratory physiology is a very pressurizing activity because you have to understand all the different pressures. For example, in normal breathing, you start off with talking about the negative intra-pleural pressure, and then you need to talk about the alveolar air pressure, and then you can talk about the transpulmonary pressure across the alveolar wall, and then obviously, as you've just said, there is the atmospheric pressure, and so on. Yeah. So this is a useful start to highlighting the importance of pressure changes in the normal respiratory cycle. Yeah. So I pause here for some interaction, perhaps. As Adrianta said, one of the things that students, including my own students, are afraid of is looking at graphs. So obviously, the standard respiratory cycle graphs has all this pressure, changes in intrapleural pressure, changes in alveolar pressure. Obviously, atmospheric pressure remains the same, and then the changes in the volume, the tidal volume. So one way of spending your tutorial time is obviously looking at the graphs and asking students to respond and describe the graph. Yeah. So I actually wrote an article 3 years ago. Be happy to send it to you. If you contact me, let me know. It's called Graphs Disease, Students' Anxiety about interpreting physiology phenomena, looking at graphs. Yeah. So that was my
Yes.
father-in-law. I'm at home, as I told you. He's
Okay.
he's curious sometimes and wondering what I'm doing. So he's 93 years old this year.
Okay.
He's still very fit. Yeah.
Yeah.
Yeah. So any input here, or we can carry on?
I think you can carry on.
Okay, right. Let's see. Yeah. Now let's briefly look at question 5. Now, I mentioned earlier when we look at question 4 that the lung will always recoil inwards. It always will tend to recoil inwards because from birth it has been expanded. Whereas for the chest wall, the recoil depends on the lung volume. It is not always inwards. Okay, so we just discussed in question 4 that at FRC, the chest wall recoil is outwards. It balances the inward lung recoil. But if you expand the lung or your thorax with a deep inspiration at TLC, at that point, the chest wall recoil is actually inwards because the chest wall is a rigid structure. So, so students sometimes have a little bit of difficulty appreciating this. So I tell them to imagine that when they go to eat their KFC or chicken, you know, the breastbone, once they've eaten all the delicious chicken, the breastbone is obviously a rigid structure. You know, and so you can just illustrate this by, if you press the breastbone, like the chest wall inwards, the recoil tends to be outwards. But if you stretch the breastbone, the two limbs outwards, the recoil tends to be inwards. So that is why the rigid chest wall structure, the recoil depends on the lung volume. Okay, unlike the lung recoil, it's always inwards. Okay, let's move to the pulmonary blood flow. This is obviously a whole area of unique hemodynamics in the pulmonary circulation. So that is why the cardiovascular system is normally taught before the pulmonary system. because you look at the general features of hemodynamics in the systemic circulation, and then when you approach the pulmonary blood flow, there are important characteristics which once you appreciate the general pattern in the systemic, you begin to understand this more. So obviously, if you look at the systemic circulation, the resistance don't change during a respiratory cycle. But in the pulmonary circulation, the reason why you do see a change in the PVR, or pulmonary vascular resistance, is that some of the blood vessels are directly exposed to the alveoli. We call them the alveoli capillaries. So when there is increased expansion of the alveoli, it mechanically compresses on the alveolar capillary, which are directly exposed. And so those vessels will have an increase in resistance. But at the same time, when you are taking a deep breath and you mechanically compress the alveoli capillaries, there are some blood vessels in the pulmonary circulation that are not directly exposed to the alveoli, but they are exposed more to the intrathoracic pressure in the chest cavity. And so at the same time, you get a compression of the alveolar capillaries. These extra alveolar capillaries, we call them, is exposed to a more negative intrathoracic pressure. And so they tend to actually expand slightly and have a slightly lower vascular resistance. And so there's this interesting opposite changes of the vascular resistance in the alveolar capillary and the extra alveolar capillary. And so the total PVR will be the sum of the alveolar capillary and the extra alveolar capillary. Now, this information is not in some textbook, but historically we have been teaching this because the late Professor Raman in my university, he reads a lot of physiology textbook, and he tries to compile a more comprehensive picture. And so you may not find this in some of the standard textbook. And so there's always a question of whether this is all that important to teach the student. Is this one of those things that you need to know or nice to know? So, but it's a useful exercise during tutorial where you can discuss about that the resistance of the blood vessel, in this case the pulmonary blood vessel, depends on the pressure inside and outside the blood vessel. One, the alveolar capillary, it is exposed to external alveolar air pressure, whereas the extra alveolar capillaries are exposed not to the alveolar air pressure, but to the intrathoracic pressure. So it is useful in terms of discussing that the transmural pressure across the pulmonary blood vessel is different in these two portions of the pulmonary circulation. Yeah, I just put this up for the sake of completeness in case some of you do have the time in your integrated curriculum to actually touch on this. So, so this may not be as much mentioned now in our integrated curriculum because the students have less time to actually cover this in lecture, as well as we are also having a drastic reduction in physiology tutorials. We used to have tutorials every week, but now maybe once in 2 months, you get one tutorial. So there's very little opportunity to discuss further what we teach in the lecture. So if this is mentioned in the lecture, the changes of pulmonary vascular resistance in respiratory cycle, and you don't have a tutorial to develop and explain further, it will be quite challenging for the student to appreciate it. Yeah.
Yes, Cheng.
Move on.
For number 6, yes,
okay.
we usually don't teach this.
Okay.
At the lecture, it's like you said, nice to know, maybe. Yes, but I want to ask, the as like the comparison or of the amount of the capillaries that are in the area of the alveoli and the capillaries that are outside. How much is the difference actually?
Yeah,
as amount?
the proportion,
Because, yeah, the proportion.
I don't have the answer to that actually.
Yes.
So I can't answer your question. They don't normally mention the contribution of the two segment of pulmonary resistance. Maybe in the more comprehensive textbook, maybe in the one that we were using, Levitsky, Michael Levitsky, for those of you who teach respiratory physiology, is actually one of the guru. Is in the same series as McGraw, where they have different titles. So Michael Levitsky wrote the one on respiratory physiology. I had a chance to meet him 10 years ago at the, what do you call that, the FASET meeting. So he was there. He has a very big beard. And so he's a very jolly person. And so I was trying to get him, Michael Levitsky, to come as refresher speaker for the physiology quiz, but he doesn't travel very well now, he said. So, okay. So he declined the invitation. Yeah, so Michael Levitsky is a good book. And I think this graph is obviously there. Yeah, definitely.
Yeah. Is this number 6 also related to the concept of blood flow at the upper lungs and lower lungs is different?
No, this is different. Yeah, this is different.
It's different. Yeah.
Yeah.
Yeah. Okay.
Yeah. So obviously, this some questions on this are asked at the international quiz, because we have a set of selected medical students who reads around more. Yeah.
Yes.
Okay. Shall we move on?
Yes. Are there any questions or comments? Yeah, you can go on, I think.
Okay. So question 7 is another area to help students to integrate respiratory and cardiovascular physiology. So this is not something unfamiliar. That is, if you take a deep breath, for example, you reduce the intrathoracic pressure, and since the cardiac chambers, we're thinking here of the right atrium, the related to the central venous pressure is decreased if you take a deep inspiration. So that helps to promote what we call venous return. Yeah. So this is why it's called respiratory pump, because it has like a suction effect of decreasing the intrathoracic pressure. Yeah. So so question 8. Yeah. Okay.
This pump is also for reasons why venous return in normal, yeah, when you are standing, still there is the respiratory pump besides the valves of the vein, and yes, the vein can constrict.
Yes.
So we usually tell this also as a respiratory pump for normal venous return. Is
yes,
this right?
Yeah, that's right. So
not only during exercise. Okay.
Yeah, that's right. Yeah. So so when you are teaching venous return, you would have
yes,
mentioned this, and then you teach respiratory physiology, and they appreciate that a bit more. Yeah. So so question 8 is very obvious to all of us as teachers, but it's interesting to ask this question at the beginning of the medical curriculum, and I had the chance to do this because the students have not done any cardiovascular yet. They have not done any respiratory, and so when this question is asked, no, the question that was asked is, where is the highest cardiac output? which organ receives the highest cardiac output. And these are freshies who just came in, unless they have some general knowledge. You will be surprised that you will get all sorts of questions like the heart, the brain, or the kidney, or the GI tract. But so this pulmonary blood flow being the highest is obviously the concept that the right ventricle cardiac output is simply the total pulmonary blood flow, because everything is pumped to the lungs. Okay, the lungs is the only organ that receives all the cardiac output in the closed circuit of the entire cardiovascular system. Yeah. So so this is an interesting question when you ask the students before they have actually entered the systems lecture. Yeah. So so if you ask a student what is the value of pulmonary blood flow, if the students are not thinking laterally, they might not be able to come up with the answer, but they will know the answer for the value of cardiac output, 5 liters per minute, they'll say. So if they link the two, then pulmonary blood flow should be 5 liters per minute. Okay. So which goes to, which also means that venous return, since the cardiovascular system is a closed loop, venous return into each side of the heart should also be 5 liters per minute. Everything should be flowing at the same rate. Yeah.
Yes. Usually the students get trapped for this number 8 question when they have already the cardiovascular section. And in the cardiovascular section, 100% of blood flow, you have a table, goes so many percent to so many percent, and then it goes most to the visceral, the kidney and the intestine. So that's why they think it goes to those organs.
Right, right.
Yeah, so they get trapped for this question because after the cardiovascular. But if you say for the organ, then it's different.
Yes.
Yeah,
Yeah.
the lungs, let's say, not.
Right.
So also they get confused sometimes. The heart also has a blood flow for the muscle themselves. And also the heart has the cardiac output. Also the pulmonary must have a circulation to feed the alveoli with blood. So these two concepts also students get easily confused.
Right. Yeah. Okay, shall we move on?
Yeah, are there any?
Any input here?
Yes.
May I say something?
Yes,
Oh,
please.
yes.
Yes, who is this?
Devi.
Hi, Devi.
Hi, Prof Cheng. No, I just want to mention that usually if we say cardiac output, then it's the blood that is pumped from the left ventricle.
Yes, yes.
So if we ask if there is what is the highest cardiac output, then the answer may not be pulmonary blood flow, because that's actually not arterial blood, but it's venous blood.
That's right. Yes. Yeah. So it's a interesting, very obvious to us as teachers, but it's important to highlight to the student that in the closed circulatory route, all the flow should be the same. Yeah.
Yes,
and,
that's right.
Yeah. And the right ventricle cardiac output is the same as the left ventricle. And then I always mention the Starling's law of the heart mechanism in the context of normalizing the left and the right cardiac output, which is sometimes not highlighted in textbook. We normally learn it as a graph or as a definition. But the most important, perhaps, in vivo reason for the Starling's law of the heart is to normalize or equalize the cardiac output from the left and the right, because of the fact that it is a closed circuit, so that you don't get vascular congestion. Yeah.
Okay, number 9.
Okay, number 9 is an interesting question because of some concepts. So I want to just highlight. So if you look at the blood pressure equation, which students all know, BP is CO times TPR. So we normally tell the students when we do this under systemic circulation that that the CO and TPR are determinants of BP. In other words, if the CO changes or TPR changes, the relationship is explained from a right to left direction. It means if you change CO, if you change TPR, then you affect the blood pressure. So I highlight to the students that in the systemic circulation, they should, as far as possible, not try to explain things in the opposite direction. That means from left to right. It means BP is CO times TPR. You cannot, it's not a simple mathematics. You cannot say when BP increase, the CO will definitely increase or the TPR increase. So the best example I would highlight to the student is that in the situation of increased chronic blood pressure, hypertension, actually the clinical picture is that you eventually will compromise the strength of the cardiac muscle and the CO actually can decrease. So in other words, relationship as in the BP CO times TPR should almost always be explained in the right to left direction. The CO and TPR are determinants. Now this question is interesting because in the pulmonary circulation, you can actually now explain the BP is CO times TPR in the left to right direction. In other words, in the pulmonary circulation, if you increase the pulmonary arterial pressure during increased cardiac output from the right heart, the pulmonary vascular resistance actually can drop. You don't see this obviously in the systemic circulation. You can't say when blood pressure increases, the total peripheral resistance decreases. It will decrease as a result of baroreflex. But here we are asking, what we're trying to say here is that the increase in the systemic arterial pressure does not directly vasodilate the arterioles in the systemic circulation. But because the pulmonary blood vessels are very compliant, you do see this kind of change, that increase in the pulmonary arterial pressure can mechanically stretch and dilate the more compliant pulmonary vessels. And this is the kind of things you see. And you get the two phenomena that we tell the students. When the pressure increases, it stretches the more compliant blood vessel. There is distension as well as recruitment. And so that actually does lower the pulmonary vascular resistance. So that is question 9 to highlight this unique. Sorry, yes.
May I ask, Prof Cheng?
Yes, please.
If the pulmonary vascular resistance is decreased, shouldn't be the pulmonary artery pressure also decrease?
No, what happened is that, so the situation is obviously quantitative. If the pulmonary vascular resistance decrease, what will happen is that explains why the pulmonary arterial pressure doesn't increase even more. Because we just said that actually the whole cardiac output is supplied to the pulmonary circulation. So if the pulmonary vascular resistance do not decrease, you would expect a much greater rise in the pulmonary arterial resistance, if not for this change, yeah.
Okay, because as I understood is that the pulmonary artery pressure may not exceed, I think, about 25 millimeters
yes,
of mercury.
That's right, yes.
Because if it exceeds this amount, then edema will occur. So
yes, that's right.
I always thought that the less increase in pulmonary artery pressure is because of the lower, the decrease in the pulmonary vascular resistance.
Yeah, the capillary blood flow is better, so that's why it's important to improve the oxygenation. So in a standard textbook, we talk about the fact that there is this mechanical vasodilation, I call it. That means just increasing the pressure will dilate and recruit some of the less patent vessels. Yeah.
Yes, the pulmonary vascular has higher compliance, if
That's
I'm not
right.
mistaken.
That's right. Yeah.
So it can passively dilate
That's right.
if
That's
there
right.
is an increase, a slight increase in the pulmonary artery pressure.
That's right. Yes. Yeah. So I just wanted to highlight that there's some of these unique hemodynamics where the BP CO times TPR can be explained in a different left to right direction in the pulmonary circulation. Yeah.
Thank you, Prof. Cheng.
Sure. Yes.
So to make this point very clear, Prof. Cheng,
Yes.
so the equation is flow is pressure divided by resistance.
That's correct. Yes.
So this is correct according
BP
to you, but
is CO times TPR. The equation
but
doesn't
not,
change. It's
yes,
just the scenario in the lungs are slightly explained in terms of the unique hemodynamics.
yeah, no, in the normal circulation, just
Yes,
flow,
yes.
pressure divided by resistance. That's
right.
a good equation according to you, but not pressure is flow times resistance.
No. It's just that, okay, the sequence of which we teach the students, as I mentioned earlier, is that we teach them cardiovascular.
Yes.
And when we teach cardiovascular physiology, all students will know this equation very well. BP is CO times TPR. And then when we move to respiratory system, I just wanted to highlight that once we move to a different system, this same equation can be understood in a different way in the pulmonary circulation.
Yeah. No, I mean for the circulatory systemic circulation, you said from left to right, from right to left. What do you mean actually? Is this the equation like flow is pressure divided by resistance? Is that correct? No. Pressure is flow times resistance. What do you prefer?
I think go to the overall big picture. BP is CO times TPR. Okay, because this equation was actually derived from what you just said. Flow is POR. Okay, this BP, systemic arterial pressure, is cardiac output times TPR. This was actually derived from the F is POR. So if you look at this equation, obviously the determinants on the right, CO and TPR, affects BP. So if they are determinants, that means you have to explain things right to left. So I gave the example that you cannot say by simple mathematics, if BP increase, CO will increase, because it's not a proportionate relationship. Because in chronic hypertension, when the BP increases, eventually the CO actually is decreased because of the increased cardiac workload. So as far as possible, I tell the students, explain things from right to left. This is what we mean.
Yeah, what do you mean from that? So you prefer the equation flow is pressure divided by resistance?
No. Look at the same equation. Don't go back to flow and pressure. It means you always explain CO change, TPR change, and then blood pressure change. Don't explain.
It's
cause
the
and effect.
Same equation. So pressure is cardiac output times resistance.
That's right. Yes.
And so you have to explain from the right to the left.
That's right.
That not from the
left to right.
Okay. Yeah. So the right is not good. If pressure increase, then cardiac output increase. Nah, not always in chronic hypertension. That's the point, isn't it?
Yeah.
Okay.
Whereas in the pulmonary circulation, as this question is trying to ask, if you increase the BP, which is the pulmonary arterial pressure, you can decrease the PVR in this case.
Yes. Yeah, this is tricky. This is tricky.
Yes,
so
it is.
Good explanation. Yes.
Yeah, it's actually a useful tutorial exercise to think through with the students if you still have some of this small group discussion. Yeah.
Okay.
Okay.
Number 10 now.
Yeah, some of the other questions are quite straightforward. I'd like to discuss more. Okay, let me just go through anyway systematically. 10, I think everybody know this is a similar situation as in the cardiovascular system. We're not comparing one small one with one big one, because in vivo you have this branching. So once we have this branching effect, the smallest airways may not necessarily have the highest resistance because of the increased cross-sectional area. So if you look at some of the textbook, the highest resistance is actually in the medium size airways, taking into consideration that you have branching effect. Okay. So
that's why in asthma, you see,
yes.
That's why a good explanation for asthma, they have the big airways that is constricted.
Right, yeah. Okay, the mechanics of respiratory pressure are also highlighted in 11. So airway resistance obviously depends on the pressure inside, airway pressure, and the pressure outside. The airways are exposed obviously to what we would call the intrapleural pressure. So if you increase your lung volume, your intrapleural pressure decreases, and so the transmural pressure across the airways, the wall of the airways will also change. Okay, so this is, I think, not so difficult to appreciate for the students. Yeah. Okay, 12 is also just to highlight to the student. So although we do have sympathetic innervation that releases noradrenaline that will tend to bronchodilate the airways, and this is obviously the basis for using adrenergic mimetic drugs to bronchodilate. Quantitatively, it appears that most of the action may actually be indirect through the adrenal medulla. That means the sympathetic, whenever it increases, directly will bronchodilate slightly, but the more greater effect appears to be through the release of the catecholamine adrenaline that circulates in the blood and binds to the same adrenergic receptors. Yeah.
You mean that the epinephrine or adrenaline is a stronger hormone to cause this vasodilation?
Yeah, so they think that from what I read,
dilation.
Yeah, that the quantitative effect is more on the circulating hormones rather than the...
Yes.
Yeah.
Okay. That's for me new.
Yeah, you can check on this, and I can't tell you the exact quantitation, but if you have information, let me know. Yeah, please educate me. Yeah.
Yeah, I always think about the nerves, because easy to see on the pictures usually. You don't see the adrenal gland involved in the...
Yeah, the problem is I can't remember where I read this. So when you are a more senior teacher, I'm sure none of us keep track of where we read information.
Yeah.
So after a while, we synthesize them in our brain, and it comes out. And perhaps it might be a good idea to
become a dogma.
Perhaps it's a good idea for essential information that you have a personal track of where you read it. Yeah, so you can, in a sense, tell your junior teachers or the students so that they can read it on their own. Yeah.
So, are you not tired?
I'm fine. We can do a few more. I think. I think it might be a good point. I was looking at the question. We can do a few more.
Yes.
I think the next few questions are useful to, let me see. Okay. Yeah, I think we can stop at 15. Yeah.
Okay. Yes.
15 is a good point to stop. And then we can continue another time. There's no problem.
Sure. Yes.
Yeah, because this lockdown, I think, might be on for a while. But we can always unlock our physiology using Zoom. Okay, right. Where are we now? Yeah, 13. Yeah, so the sequence of lectures in our respiratory module, obviously, is that we will teach about alveolar ventilation first. And then we will say to the students that alveolar ventilation is important to maintain the alveolar air partial pressure of oxygen and CO2, which is not wrong. But once we move to more detailed information, the respiratory system is quite unique in that the students not only need to know airflow, but also blood flow, because it is all about exchange. It's not just airflow into the alveoli, but you also need to think about how the pulmonary blood flow interact with the airflow. And this is where the contribution of the perfusion, the pulmonary perfusion, also actually affects the value of the alveolar air pressure for oxygen and CO2. So this is basically to highlight the importance of ventilation perfusion balance. So strictly more accurate is that the ventilation perfusion ratio, not just alveolar ventilation alone, determines the alveolar air partial pressure of oxygen and CO2. Okay, so so perhaps let me highlight, let me skip question 14 and to highlight what I've just said. 13 and 15 are the same. So, okay, 15 is asking the question, why is alveolar air partial pressure higher at the apex of the lungs? Now, when we describe to the students about the base and the apex changes in the upright lung, we always tell the students that the alveolar ventilation is more at the base, right? It's more at the base, upright lung. And we also tell the students that the ventilation is also more at the base in the upright lung. Yeah. So, so the easy way I tell the students to remember, even if they can't work out why the alveolar ventilation and the perfusion is better at the base of the lung, is that both are better at the base. The alveolar ventilation and the pulmonary perfusion, for their own reasons, is better at the base of the upright lung. So I tell them that things are not always better at the top. Yeah. So of course the reasons for that is different, but we won't go into that. I think all of you should be able to explain that. But the question 15 is that although the alveolar ventilation is better in the base, those respiratory physiologists who spend all their years analyzing values of partial pressure of oxygen and CO2 at various levels of the lung actually found that the partial pressure of oxygen in the apex, which has less alveolar ventilation, is actually higher. Which sounds strange, right? If you read it as a sentence.
Not
Alveolar
really.
ventilation is better at the base, but the partial pressure of oxygen in the alveolar air is actually better at the top.
Because the diffusion rate is less.
That's right, yes. So basically this is to highlight that you need to think about VQ balance rather than just the alveolar ventilation alone. So the perfusion also decreases at the top as you move from the base to the top. And so it is the ratio which is actually the final determinant of the PO2, yeah. So this is perhaps is a final point, but useful to help students to grasp the concept of VQ balance, yeah. So this incidentally, in terms of lung pathology, may be an interesting information to highlight TB, because TB, the aerobic TB bacteria tends to prefer it may be related to the fact that it has a higher level of oxygen at the apex. Yeah, VQ balance is a whole topic on its own. Not easy to teach, and not easy for students to appreciate. And they would obviously sometimes ask, why do we need to learn this? When they say, is it important? when students ask, is it important? They are normally thinking about exam. Is it important for exam? Other than whether it's important for life.
It will be good for coffee because they talk about that very much. Ventilation perfusion. When the patients go to the ICU, there must be something wrong with these two parameters.
Yes. But I try to highlight to the student that, for example, in nursing practice, depending on which lung is more affected, lying the patient on whichever side has something to do with the VQ balance application, so that the patient's symptoms are better in terms of their alveolar ventilation.
What about the prone position at the ICU?
Yeah, so this is interesting because recently for the COVID patient, there have been recommendation of lying the patient in a certain position. Am I right? I've been reading about that.
Yes.
Yeah, so there's been a couple of articles I was trying to understand, and it has to do something with this VQ relationship. Yes.
Very much, I think.
That's right, yeah. So those of you who are respiratory physician here might be able to explain a bit more, Yeah.
Also, it's difficult for the patient to have that position because when they are on the ventilator, all those tubes on all those IV sets, I don't know how they can do it. But it seems the prone position is better than just lying normal.
That's right, yeah.
Oh, very good. We touched good things, I think, this morning.
Yeah, it's a good point to end, since in this corona season, we're talking about position, posture of the body, and improve ventilation. Yeah. So there are other questions. I'm happy to interact with you all. This Dr. Adrianta has my WhatsApp. Feel free to contact me.
Yeah, you can feel free to ask Professor Cheng a question.
Yeah,
Professor Cheng, I don't know about the answer of number 17, just like that, and he will answer you.
Never mind. We can discuss this either together. We can discuss together, or maybe on a personal basis. If Adrianta, if you could just show the colleagues here the other two sets of notes, just to explain what they are. So send to them. So the next set of notes is actually another way of in which I try to interact with my students. This second set of notes is called not physiology, not as in NOT, not. So this is basically formulating definite negative statements using the word not in the sentence related to respiratory mechanism that highlights for the students some essentials in physiology. So I send it to Adrianta. She can send it to you as a note. I found this quite useful. I've done this also for the renal system and the cardiovascular. And you can, in your own teaching experience, come up with your own. It's just to help students to have a handle on certain important, definite.
Can you see this?
Not yet. Okay, this is called not respiratory physiology. This is already in one of my books called Conceptual Learning. So this paragraph here says, making definite negative statements can be useful to define and clarify thinking when learning physiology. So this is obviously not a comprehensive list, but just to leave it with you to think through. So below are some of the notes to take note. So for example, what we discussed, number 2 here, lung elasticity does not mean stretchability. And this is a brief explanation. So there are various things here. I think how many notes are there? Adrianta, can you scroll it?
Nice, 20.
20 knots. Okay, yeah. So you all are welcome to add to the knots and send me your knots so that I can also learn from your
100 knots.
so that I can also
we have 100 knots.
your
Yes.
thinking. Yeah. So
Yeah.
so these are useful from my own experience. And then the last note that I can ask Adrianta to send to you is just a humorous, half humorous note using the 10 commandments. I've called this the respiratory 10 commandments or the respiratory decalogue. So these are again not comprehensive, but certain essential notes for the students to hopefully enjoy a bit more of the physiology. Yeah. So are you sharing, Adrianta? Or
To all the participants here, Dr.
Can I ask a question?
Yes, please, Hadi.
Okay.
Thank you very much, your excellent lecture. I would like to know about the textbook that you wrote, the title, and also you mentioned about the name of one of the lecturers in physiology, the beard one, is it?
Oh yeah, Michael Levitsky. Michael is Michael. Levitsky is Levitsky. Levitsky. Yeah, it's just called Respiratory Physiology.
I'm concerned in Indonesia because a lot of high mortality because of COVID. Most of them is the respiratory, hypoxic respiratory failure. And I observed in my survey as DPRS in the hospital, something like supervisor throughout the hospital in South Sumatra. Once the patient got the ventilator, gone. Besides the concept of the pathophysiology of cytokine burst or hypercoagulability,
Right.
I would like to know, but if you know something that we can contribute something in the lung physiology and pathophysiology for the respiratory physiologists or anesthesiologists. It seems to me there is something wrong. Once they got the ventilator, most of the higher mortality.
Yes, yes.
So I want to make a high reliable healthcare,
Yes.
What kind of something that in the lung physiology that we can, lung physiology or pathophysiology, that we can contribute to all our colleagues.
Yeah, I have read about the reports a couple of weeks ago about those on ventilators seems to do worse. Yeah.
Do worse, yeah, that's right.
Yeah. I don't have the clinical background to answer your question. I'm not a respiratory physician. Yeah, so yeah, I don't know the answer, but there was some discussion about why in the papers, I can't remember the explanation, why certain patient should not be immediately put on the ventilator. Yeah.
It seems to me, because I treated the patient in early March. I got two patients at the time, one from Singapore and the other one from Malaysia.
Oh.
They had a medical checkup over there for heart disease. And then they got COVID. Coming back to Palembang.
Right.
I treated the patient as first to counter the cytokine burst and check for the hypercoagulability and try to avoid ventilations, because, and then both of the patients survived. The patient is about 73 years old. So maybe I'm thinking about what we can contribute from the lung physiology or pathophysiology to this anesthesiologists or respiratory.
I can't remember where I saw the paper, but they had some guidelines on measuring certain parameters in some of these patients to recommend whether they should be immediately put on ventilator. I can't remember the parameters they were thinking about. Yeah.
During my observation, I saw these clinicians in the ICU dealing with the COVID patient. They are not checking very well, thoroughly about the physiological parameters.
Right.
Yeah.
Yeah.
We have the physiological parameters in the ICU and so on, you know.
Right.
Especially dealing with the ventilators.
Yes.
Yes.
If I can find the article again, I will.
Yes, thank you.
I will send it to Adrianta to distribute. Yeah.
Yeah.
Yes. Also, there is ventilation with non-invasive and invasive. The one invasive is very bad, he said. The non-invasive ventilation is still maybe okay. So you don't put the tubes in the air, just non-invasive ventilation. Maybe that's better. I don't know. We have to look for it. Okay. So thanks, Professor Cheng.
Yes. So we can.
Very good session this morning.
Thank you for coming and interacting here. So we can make this a fairly regular, informal session among physiologists. Yeah.
Yes. And thanks to Dr. Yuni, the host.
Yes, thank you,
The
Yuni.
Zoom is very clear.
Yes.
No interruption. So,
yes.
And also the pictures are very nice.
Shall
Maybe
we take
should make a picture
before
stopping.
Yeah, Uni can or somebody can.
Who can
screen
take
print
a picture? So please, everybody, put the video on.
That's right.
Please put your video on. Yes, so I can see you.
Sorry, I cannot turn on my video.
Okay, okay, it's okay. Most of you can.
Excellent. Yeah.
Dr. Yusi, Dr. Agni, Dr. Sakya. Yeah.
Okay. Somebody can screen print for us. Uni, maybe.
Okay. Who will take the picture?
The host, please.
The host doesn't have the camera.
I cannot.
Is the host
Siapa
there?
yang bisa ambil gambar?
Oh, Aminia is doing okay.
I will
Aminia,
take a
bisa?
picture.
Okay, let us know.
Yes, I will take a picture. One, yes, 1, 2, 3.
Once
1,
more.
2, 3.
Okay.
Next. Because there is two part, and then.
Okay, two parts.
Okay, 1, 2, 3. 1, 2, 3. Okay, thank you.
Oh, thank you so much. Okay.
Thank you, Prof Cheng, for the lecture.
Welcome. Yeah. Welcome.
Thank you, Prof Cheng.
Yeah.
Thank you, Prof Cheng. Yeah.
Thank you. Right.
Adrianta, terima kasih.
Bye-bye.
Thank you, Prof Cheng. Terima kasih,
Dr.
Dr.
Adrianta.
Thank you, Adrianta. Thank you, Yuni.
Terima kasih, Pak Adrianta.
Ya.
Terima kasih, Pak
Sehat
Adrianta.
selalu. Ya.
Ya, makasih Dr. Adrianta. Dr.
Sama-sama.
Hadian, apa kabar?
Ya, terima kasih. Selamat pagi, Bu. Selamat pagi, Dok. Ya.
Ya.
Iya. Mas Aki, Bu Indri, makasih. Ya. Iya. Terima kasih. Ya. Sampai ketemu
Oke.
lagi. Ya.
Ya, sampai ketemu.
Sampai ketemu lagi. Ya, makasih.
Terima kasih, Dr. Yuni.
Terima kasih, Dr. Yuni.